patient, 35-year-old female and 36 weeks pregnant, present with the painless vaginal bleeding. And let me give you something. I always guide you because that's what the case study will come up with, so that you can. I do this so that you can start thinking. I know by just reading like that, I know what to actually expect. So when I look at the answer choice, it's easy. Diagnosis here, you'll be able to know what we're talking about. What is your plan? Do you need a 20 gauge IV? Do you need a type and cross oxygen bed rest vaginal ultrasound in CBC? I can tell you we need an IV, right? We have to type and cross. What about the rest? He's having painless vaginal bleeding. Of course, oxygen is not a bad idea, right? I mean, we make sure she's at bed rest. Anybody, the key with concept with OB, if somebody is bleeding and you don't know why she's bleeding, you never put anything in the vagina. So transvaginal ultrasound is not a good idea. And then we get a CBC. Okay, so this is what we're going to do. If we have to do ultrasound, we did trans-abdominal ultrasound. Find is the cervical arch. It's covered by the placenta. So what is our diagnosis? So somebody said placenta previa. So we have our diagnosis of previa, right? Now, she's 37 weeks. She's bleeding. But we have the placenta covering the cervical arch. So we can't do anything. So if this is the uterus and this is the vagina, we have a placenta sitting here like that. So we can deliver the baby right now, right? So the patient was placed on bed rest as we have a plan. It was type and cross. Blood is available. IV was placed. And we tried to observe the patient. But she continued to bleed. And then the hemoglobin dropped to like 9. And then we saw deceleration, late decel. That is like frequent, multiple late decel. What is your plan? What are you going to do now? She's bleeding and she has multiple. So we have a problem. We can't do vaginal delivery. So you can't do vaginal. So no vaginal delivery because of the previa. And she's still bleeding. She's having decel. Okay. So we can, that's late decel is placenta insufficiency. So at least we have oxygen available, mommy on the left side. Okay. We notify anesthesia and plan for C-section, right? That's what she's going to do. So she has uneventful C-section. Everything went well. Postpartum. Now she's 6 hours. Postpartum. The next day, the assessment, and she saw oozing from IV line, oozing blood from IV line. That's number 1. Number 2, yeah. So which one should you worry about? 6 hours, she's 6 hours postpartum. This is which one is concerning to you. Somebody said 3 is concerning. Yeah, nosebleed is not good, right? 2 is concerning, right? She has pinpoint rash. This is what we call petechia. It's not good. Temperature is fine. Within 24 hours, this is okay. Okay. Heart rate of this is okay. And urine output, 100 ml over 6 hours. That is less than 20 cc per hour. So this one is bad. So 2, 3, 4, 7 are concerning to me. So 2, 3, 4, and 7 are concerning. Think about what is happening. She just had a baby, 6 hours. It's oozing from the IV line, and nose is bleeding. She has petechia. Her urine output is low. What do you think she's a diagnosis? The plan, let me change it to like, what do you expect? Let me go for there first. So expected, unexpected, right? Based on the physical exam, if I give you a lab work and I said, which of this do you expect, right? So tell me if you expect that. Platelet, high. Fibrinogen, high. Okay, PTT, low. PT, low. IM, high. Right? So that's what I've given you. Tell me if you expect this. If you say it's a DIC, which almost everybody was able to pick it up based on physical exams, then you should tell me if it's expected or not expected. DIC, disseminated intravascular coagulation, is a consumptive. You chewing your things, all your coagulative factors is being chewed. When you chewing them, it's a consumptive. You chewing things, your fibrinogen is not going to be high. It's going to be low. Your platelet will be low. Your PTT, INR will be high. So they are not going to be expected. So I put low here and low. So they are all wrong. PT will be high. PTT will be high. Fibrinogen will be low. Platelet will be low. And the INR will be high. So that is the only thing you're going to see. This is the picture is going to be. So those are the things you have to look at and be able to use them. Now we make the diagnosis and we know what the patient is suffering from, right? So patient was given the treatment for this. She's going to get blood. She's going to get platelet. She's going to get FFP, fresh frozen plasma. That will give her fibrinogen, and that will take care of everything as much as possible. Okay, you have to monitor for certain things. Okay, you have to monitor for shock, and so what you'll be paying attention to is urine output, mental status, okay, and their heart rate and the blood pressure. So those are the things you'll be monitoring. Now, so I've taken you to the next step. Patient continue to bleed, no matter what we do. So bleeding, hemoglobin is now 7.5, and she's bleeding vaginally, so vaginal bleeding. And nosebleed is fine. So nosebleed, I stopped. The IV also I stopped. What would you do with this patient now? I will give you a clue and tell me if it's indicated or not indicated. She's still bleeding. So I would say transfuse again. I would say what else? Give her oxygen. oxygen. I would say 2 liters nasal cannula. This is number 2, 3, 4, 5. She's still bleeding. We know she has DNC and she's bleeding from the vagina, right? So what are you going to do? I can tell you that she needs some blood, right? I can tell you that she needs IV fluid. How about the rest? Will you put a 2 liters nasal cannula on there? Do you massage the uterus? Or you take the patient and get a hysterectomy, right? That's what somebody said. Nasal cannula is a bad idea. I told you before, any pregnant lady in dash distress patient who's at risk for shock, you want to put a non-rebreather. At least 10 liters is very good. That will improve oxygen to the placenta. So not indicated. You should not massage the uterus in this situation. The massaging is not going to help with that. You know she's in DIC. This has nothing to do with anything like that. So it's not indicated. Now, we have to take the patient to surgery. We did a hysterectomy. She did well, and she was discharged home with the baby. So she was discharged home with the baby. Everything was fine. So 3 weeks later, this is what she said. Okay, she refusing assistance from the mother. Why? Because she's worried that the mother is going to poison the baby. That's one thing she's saying. She said the milk is contaminated. Breast milk is contaminated, so she wants baby formula. The breast milk is contaminated, and so she wants a baby formula to feed the baby. What do you think is going on with that patient? What is going on? What do we have here? She's 2-3 weeks postpartum. Think about it. Okay? Think about it. It cannot be blue, because blue, even though blue occurs within 2 weeks, blue does not do that. Blue will not refuse assistance from mother or poison, and they think that the mother is poisoning the baby. Okay, it can be blue. And blue will not be saying that a milk is contaminated, so she wants the baby formula. Blue will be not doing that. What do you think is going on? You have to interpret this information, otherwise you lose a point in the case. So, a mother that's the client's mother will be trying to harm the baby. No, she's not. That's not a depression. That's no blue. This is psychosis, right? She has psychosis. And these are all delusional thoughts. These two are delusional thoughts. She's having this delusional thought, and this will put her into psychosis. So this is psychosis. So treatment, inpatient, admission, or inpatient rehab, basically. So that's, you should be able to distinguish between the 2 and the 3 so that you don't get trapped. So this patient will be admitted and will need psychotherapy and the management. So this is key, inpatient rehab. So inpatient rehab. And then was given Risperidone. There was given Risperidone. Okay. And was sent home with that medication. She came back 2 weeks later, and with the nurse examining her, she can't stay still. Okay, can't. still, spacing all around. And what else she's doing? She's very agitated. She can't even sit still. What do you think is wrong with this patient now? This is what we call akathisia. Okay, it's extrapyramidal side effect, but it's called akathisia. So you have to be specific. Your board will not give you that. So this patient is showing akathisia symptoms. Okay, it's not maniac episode either, because the patient is not on what, a mood depressant. Risperidone is an antipsychotic, and if you take an antipsychotic, you can stay still, you pacing and you agitated within a very short time. This is for akathisia. What is the treatment? So what do you give this patient to help with this patient? So what? Medication you can give him. Benzos, it's excellent. So you get benzos, so diazepam, or you can get a beta blocker or benztropine. But the first agent is something to slow them down. So the first agent is a beta blocker. Just give them a beta blocker, followed by either benzos, then they can get benztropine. But those are the things, the triple Bs, I call them, the triple Bs for akathisia: benzos or beta blocker or benztropine. Benztropine, another name is cogentin. So that's the same thing. But you have to give them beta blocker that will slow them down. You follow that with the benzos and then benztropine. So she developed akathisia from risperidone. I've taken you to pharmacology, and since pharmacology is my favorite, I will stay there, right? So she did well. We slow her down because this was a very quick. She developed psychosis from this, but this resolved within 3 months, and then they stopped the medication. So 3 months, they stopped the medication. And she followed up 2 months later. Now she's showing these signs, psych pharmacology, right? I've given you signs and symptoms of depression. You should be able to recognize it and say, oh, this is signs and symptoms of depression. I don't think I spelled this right, or CHO, yeah, psychomotor agitation. So this patient is now depressed. Depression. So we have so many options. Unfortunately, the doctor decided to give this patient, what did he put the patient on? Fluoxetine. And these are the statements she said at discharge. Do you need to intervene or do you don't need to intervene? Somebody said intervene for ibuprofen. That's what he said. So intervene. Somebody said 3, libido up, to say intervene. That's what the person said. Somebody said intervene 1 to 6. So 1 to 6. Exercise. Oh, so this is exercise. I don't mean this is exercise, not excessive. Exercise 3 times a week. That's fine. She's going to gain weight, so no need to intervene. So 2 is fine. You don't need to intervene. Libido is not going to go up. It's going to go down. Ibuprofen, SSRI, they affect your platelet and they cause bleeding. So one of the side effects of SSRI is platelet dysfunction, and therefore ibuprofen is bad, so intervene. Follow up in 2 weeks. Yeah, suicidal ideation. I don't need to intervene. That's a good idea. Sleep will go down. Yeah, you get insomnia. No need to intervene. Stop med in 2 weeks. If you know effect. No, it takes like 3 weeks for you to see some effect, so intervene. And the last one, what do you guys think? What do you think? Number 7. Number 7, you cannot take sumatriptan is used for migraine. So used for migraine, and it's a serotonin derivative. If nobody have told you before, every time you see sumatriptan or triptans, most of triptans have serotonin in it. So you cannot take it with SSRI. Therefore, you should intervene. So this is what the table would be. As you can see, I know how to say it in NGN questions, you can see the way. So these are but it's our concept. So you got to intervene here because it's an SSRI. They cannot take SSRI together with that. So yeah, these instructions was given to the patient. How did you explain number 4? Number 4, she need a follow-up in 2 weeks because that is the time, that is the time they're going to have suicide ideation. The first 2 weeks is dangerous. So every time you give somebody SSRI, you got to follow up, or antidepressant, you got to see them in 2 weeks because that's when they are risks of suicide. So that's why we don't need follow-up in 2 weeks is appropriate. So that's good. Like I said, these are content I'm using to make these NGN questions. And that's what you see. Your board will give you in the Q bank is the same thing. They just take the content, right? So now, patient follow, or you intervene, you teach her and everything. Unfortunately, she broke a leg. Okay, and was seen in the emergency room 2 weeks later. And because of pain, they give a tramadol. Are you worried? Tell me if you're worried. If you're worried, then why? She broke her leg and then she was giving tramadol. Tell me if you're worried. Some people said they're worried. Excellent. If you're worried, well, which of the following you're going to expect? See, I love endeavor. I can make things up the way I want. 7. You said patient was on what? Fluoxetine, right? Came in with the leg broken, and the doctor prescribed fluoxetine. And you say you were prescribed tramadol. And I said, okay, which of this should you see on exams if you worry about it? Which of this do you think you'll be seeing on exams? Which of this? Which of this are you worried about? You make the diagnosis and then you can figure it out. Yeah. I can tell you what is if you worry about this, why are you worrying? We worry about serotonin syndrome. If I'm worried about serotonin syndrome, keyword is everything is up plus GI symptoms. That is the way I want you to remember it. Serotonin syndrome, everything is going to go up plus GI symptoms and clonus. So I see clonus here, that is the key, expected. All this is a GI symptoms, expected. Look at the way I'm answering that question. Everything is up. Diaphoresis, I don't know what it is, but I know it's going up. I don't care what they put there. So far as that symptoms is going up, I'm picking it. Heart rate is up, I'm picking it. Temperature of 102 is up, except when it's close to 104, 105, serotonin syndrome will not go there. This is neuroleptic malignant syndrome. Serotonin syndrome will stay in 102. So once again, serotonin syndrome, everything is up, plus clonus and GI symptoms. So these are all what you should expect in this particular patient. is really bad. So because the doctor gave the patient Tramadol while she's on Placenta. So we should not do that. So we're able to take care of this patient. Most of the time, this patient will need the benzodiazepine, the same thing, the benzos or beta blocker, try to cool them down and then get rid of the problem. So that will be the treatment, benzo, beta blocker, and try to cool them down as much as possible. Okay, now, I don't know where the case will do, but patient did well. Unfortunately, was resistant. Depression was very resistant or refractory. And so we decided to do ECT, electroconvulsion therapy. We've given it everything. We couldn't fix anything. So we decided to do electroconvulsion therapy. Intervene through, it's the same language. They try to confuse you. It's the same. Don't worry about it. So for us, one is true, the other is false. The true one, you don't need to intervene. False one, you get to intervene. So which one is true? Which one is false? I can change it. The same question, I give you different words. So which one, right? Which one? What do you think? Should you stop your medication? Do you need one treatment? Is this going to be painful? Do you have to wash your hair? Do you need this? You're going to be induced seizures for 1 minute during the procedure. Sedation, you need okay to have caffeine, right? And then you're going to get retrograde amnesia. What do you think? Right? What do you think? True or false? Do you stop your medication? No. False. You got to continue taking your medication. Don't stop it. So don't stop it. Do you need one treatment? No, you need about 6 to 12 treatments. So this is false. Is the procedure painful? No, it's not painful. False. Do you wash your hair? Yes, wash your hair. Seizures, yes, we're going to induce some seizures, but 1 minute is too much or it's too long. It's usually 15 to 20 seconds. It's seconds. So not 60 seconds, 15 to 20 seconds. This is false. You're going to get some sedation. Caffeine is not okay. It's a stimulant. You get a retrograde amnesia. So this is what the concept with electroconvulsion therapy. Trust me, if you're going to see, if you go to the Q bank or any place in the exams, and anybody will give you ECT, electroconvulsion therapy, this is the content. This 2-second slide, it has everything you need to know on electroconvulsion therapy. You don't stop the medication. You need 6 to 12 therapy. It's not a painful procedure. The patient needs to wash their hair. We're going to induce seizures for 15 to 20 seconds. We'll give you some sedation. You should not take any stimulant. And you're going to have retrograde amnesia. And the nurse is supposed to rearrange you at the end of the procedure. This is that, right? Stop meds means the patient is depressive, he has depression. So they should not stop their depressive medication, antidepressant. Antidepressant medication, antidepressive medication, they should not stop taking it. Okay, so that's what I mean, stop medication. So this is what we have. Okay, so this is what it's going to look like. Well, we were able to fix the problem. We fixed the problem and the depression get better. But later on, 6 months later, this is the end. I think it's almost 1 minute I have. I will put this one there. 6 months later, she came in, okay, with distracted, very easily distractible. So distractible. She has impulse issues. Okay, grandiosity, basically raising herself up above everything. She's really fast speech, right? Her activity is like nonstop. Okay, and she can't sleep, so she has insomnia. And she's talking nonstop. What is your diagnosis? After we treat her with depression, this is where we come in. 6 months later, she's easily distractible. She has impulse problem, and she has grandiosity, and then fast speech. Let me see. Fast speech, and then activities she can't sleep, she's talkative. So we give them sedation when we're doing ECT because we're going to induce seizures. So we got to sedate them a little bit. They get some propofol and other medication to paralyze them. So we give them seizures. So that's why we give them that. So somebody saying sedation will affect the treatment. No, it doesn't affect. You give them some sedative medication because of the seizures you're going to induce. So she came in 6 months later after treatment with very distractible, impulse problem, grandiosity, fast speech, activities up, sleeping, and talkative. What do you think now she has turned into? She has turned into what somebody else, right? She has a depression. All of a sudden, she can't stop talking. She's walking nonstop, and it has turned into what? It looked like everybody get the answer. Everybody is able to figure out what I'm trying to show, right? So she's in a maniac episode, right? Therefore, which of this, we have a maniac patient now. Now, well, you give them clozapine, you give them bupropion, lithium, risperidone, IV fluid, group therapy, burritos, and a salad. What do you think? This is on the go learning. If you hear my voice for the first time, like I've said before, tap NCLEX. Thank you for watching. And then I will appreciate if you like this video, you're sharing. But this is Adapt NCLEX. I'm about to sign out. This is the last one. If you want to join our review, join it. You can subscribe to our channel or join our membership. So this is what we have. This is what we want to treat the patient. She's in a maniac episode. What do you think? What do you think? As I've said before, I know I don't get 10,000 views, so nobody will see the video. You won't be lucky, but when you see it, you are lucky. So because YouTube try to share videos that have 10,000 views, but when you get it, hey, you count yourself. You do the plus sign, say hallelujah, right? So what do you think? Which one is indicated in a patient in a maniac episode, right? In a maniac episode. I think the key concept is they can get antipsychotic, okay? They can get antipsychotic, and they can get mood stabilizer. So clozapine is an antipsychotic. You can choose that. Risperidone is an antipsychotic. Which one? Second generation is good. So pick a second generation antipsychotic. It will help with your mood stabilization. So clozapine and that. Lithium is a mood stabilizer, right? IV fluid, physiological need, right? Before psychological need. Group therapy, no. Individual therapy with the nurse. So this is not indicated. You want to give them finger food. So this is indicated. Salad, he has to sit down and eat, unless it's in a burrito form, yeah. So salad, something you got to sit down and eat your salad, right? You know, I don't think he will be willing to sit down and eat. So You want to give him something he can carry it. If it's in the burrito form or it's in a sandwich, but raw salad, you can eat raw salad by walking, right? Unless in the small bowl or something. But I can't make sense out of it, so I put salad by. You can select it or not. You can make it the way you want, but the point I was trying to emphasize is don't give them anything that they will sit down and eat. You want to give them something they're going to walk and eat. So I'm not going to give them this patient this one. This bupropion, you should avoid it in a maniac patient because they give them too much energy. Bupropion give them too much energy. So this guy is in digging fast mode. We don't want him to dig fast anymore. We want to slow him down. So not indicated. This is what you see. We start with the lady who is pregnant, came with placenta previa. We managed the placenta previa. We couldn't control it. She developed DIC. We treated the DIC. She went into what? Ongoing bleeding. We have to do hysterectomy. Post-op, she went into a psychosis. We managed the psychosis. We put her on antipsychotic, developed akathisia, managed akathisia, developed depression. We put her on an antidepressant, developed serotonin syndrome. And then we treated her depression. She became refractory. We did the ECT to manage the refractory disease. And in the end, she went into maniac episode. How many cases have I done with you in an hour? Thank you for watching. And I guess Adult NCLEX deserve your liking. Take care of yourself and be good. Bye.